In this session, we will take a look at sebaceous carcinoma. There are two types of sebaceous carcinoma: ocular, in which it involves the orbit, conjunctiva, and eyelid, or extraocular, often on the head and neck, especially on the face, lip, and ears. In this type, think about Muir-Torre syndrome. The age-adjusted incidence rate is 0.07 to 0.18 per 100,000 person years. It often affects the elderly and more in males, except in Taiwan, but for the ocular type, females more than males. It often presents as a painless, slow-growing nodule. So on the left, you see a picture of an ocular sebaceous carcinoma, and on the right, an extraocular one. In terms of etiology, this arises from the sebaceous glands of the eyelid, and there are problems with the DNA repair mechanisms, as in Muir-Torre syndrome, HER2 new amplification in the ocular type, as well as mutations in the phosphatidyl ionositol 3 kinase signaling pathway. These are the risk factors for sebaceous carcinoma: ultraviolet radiation, increasing age, genetic susceptibility, as well as immunosuppression. For histopathology, in sebaceous carcinoma, you find poorly differentiated basaloid cells in sheets with an infiltrative growth pattern. It is cytologically malignant with atypical and frequent mitosis. Mature sebocytes are variably present and may be focal. For the ocular type, there is often epidermal involvement with pagetoid spread, which you can assess using conjunctival map biopsies. So on the left, you see a H&E picture for a prominent nucleoli in atypical seboblasts and characteristic multivaculated pleomorphic sebocytes with scalloped nuclei. And on the right, you see pagetoid pattern for in situ sebaceous carcinoma. For IHC, for sebaceous carcinoma, EMA is positive, CK7 positive, BER-EP4 variable, adipophilin is positive, vesicular, androgen receptor positive, and importantly, factor 13A is positive. Clinical differential diagnosis are chalazion, blepharitis, and BCCs. For histology, if sebaceous differentiation is not conspicuous, it can look like poorly differentiated carcinomas, whether BCC, SCC, or metastatic carcinoma, as well as melanoma in situ. In terms of prognosis, there is a 92% 5-year and 79% 10-year age-matched relative survival rates. Regional metastasis rates are ranging from 2.4% to 28%. Poor clinical prognostic factors are delayed diagnosis and size more than 1 centimeter, while poor histologic factors are poor differentiation, pagetoid spread, multicentricity, size more than 1 centimeter, and lymphovascular or perineural invasion. So there's a 16.5% local recurrence rate in this paper by Vel et al. In 2022, with a median time of 19 months, and risk factors were periocular tumors and those with positive resection margins. There is infrequent local, regional, or distant mets. Always remember to palpate your lymph nodes, and distant metastasis can occur in the liver and lungs. You always need to check with the patient for a personal or family history of GU or GI cancers, and investigations can include CT or MRI looking at orbital invasion, LFT, chest X-ray, and PET-CT scans. So this is the AJCC classification, which you can look up. And in terms of treatment, white excision can be used. Conventionally, for US guidelines, you need to take 1 centimeter margins to the deep fascial plane. Alternatively, you can use Mohs surgery. In terms of treatment, for radiotherapy, adjuvant RT can be used for patients with regional lymph nodes, extraocular type with perineural invasion and positive margins. For radiotherapy as a sole treatment option can be used for patients who are poor surgical candidates, recurrent tumors, as well as for palliation. For nodal disease, lymph node dissection is recommended for radical treatment. For those with the ocular type, you may need a neck dissection with parotidectomy and adjuvant RT. Sentinel lymph node biopsy should be offered if the patient has ocular sebaceous carcinoma more than 1 centimeter in size, stage 2C and above. Cryotherapy can be used as an adjuvant treatment. You can also offer chemotherapy with topical mitomycin C, systemic neoadjuvant or adjuvant therapy with cisplatin or carboplatin and 5-FU or paclitaxel. Pembrolizumab can be used in patients with unresectable with MSI or high tumor mutation burden. Exenteration can also be considered in certain cases. And if the IHC shows loss of expression in MLH1, MSH2, MSH6, or PMS2, you may refer to the geneticist. Remember to screen for Muir-Torre syndrome in patients younger than 50 years of age and sites other than head and neck. This is the Muir-Torre syndrome risk algorithm, looking at the age, total number of sebaceous neoplasms, personal history or family history of any Lynch-related cancers. This is an algorithm for the management of extraocular sebaceous carcinoma. So for a patient with a suspicious lesion, do history and physical examination, looking at the complete skin and lymph node examination, biopsy, including the full dermis and extension into subcutaneous fat, and imaging studies as indicated for suspicion of extensive disease. If it is indeterminate, consider rebiopsy and look at IHCs positive for nuclear factor 13A, androgen receptor, adipofilin, and perilipin. If you have confirmed a diagnosis of sebaceous carcinoma, consider the need for imaging, either ultrasound or CT scan, and evaluate the extent of any clinical lymphadenopathy. Risk factors, ear or lip location, azathioprine use, and cell markers, and see whether patient is node positive or metastatic. So if patient only has local disease, you can consider Mohs surgery or CCPDMA. Otherwise, you may require wide local excision up to 1 centimeter margins. And if ineligible for surgery, consider radiotherapy. For those with suspected nodal disease, they will require surgery for local disease, excision of the involved lymph node, and consider radiotherapy or complete lymph node dissection of the nodal basin. For patients with metastatic disease, you need to consult with the medical and surgical oncologists. And for those with resistant disease, you can consider clinical trials or experimental targeted therapy. For patients with periocular sebaceous carcinoma, these often present as persistent unilateral blepharoconjunctivitis or a unilateral nodule in the eyelid, caruncle, or conjunctiva longer than 6 months. So first we biopsy, and if you confirm a diagnosis, check the lymph nodes as well as a basic eye examination. If negative, they require local control only. If positive, you need to do a CT scan of the head and neck for lymph nodes as well as an MRI brain for deep invasion. If there is no pagetoid disease on biopsy, we look at the left arm. Otherwise, for pagetoid disease, you need to consider MET biopsies to assess the tumor spread. So then, for treatment, you can excise the lesion using CCPDMA or Mohs micrographic surgery. If the surgical margins are positive, consider adjuvant cryotherapy or mitomycin. For those with incomplete response, they may require orbital exenteration and followed by radiotherapy. For patients who have complete response to surgery, look at the final tumor stage. For patients stage 2C or higher, you need to offer them a sentinel lymph node biopsy or lymph node imaging. If positive, they need a complete lymph node dissection or radiotherapy and a PET-C2 to assess for distant mets. So for patients who have lymph node disease, you will need to offer them excision using CCPDMA or Mohs micrographic surgery, radiotherapy or exenteration for local control, followed by your complete lymph node dissection or radiotherapy and PET-CT scans. And with that, I thank you.